Hello, everyone. So now we're going to continue with the aminoglycosides and another very common antibiotic used in hospitals with very, very special indications. So let's do a review of them. So aminoglycosides are also bactericidal. That means that they don't kill the bacteria. They inhibit growth and multiplication. The most common ones, gentamicin, tropomycin, amikacin. So most of them, they have that mycin sound at the end. Aminoglycosides are very good for aerobic gram-negative bacilli. So make infections where the bacteria can breathe. That's what aerobic means. This infection, we can find a gram-negative bacteria that can breathe. So it can be used for pneumonias. It can be used for infections on the skin where there's oxygen. The only problem with aminoglycosides is they have severe adverse effects with the ear and the kidney. And unfortunately, because the abuse of antibiotics, we're seeing a resistance. So that's a quick overview. So adverse effects, nephrotoxicity or kidney damage, ototoxicity or ear damage. So it's very important, and we're going to continue mentioning this, that every time you have a patient with aminoglycosides, is always follow with serum plasma levels. So we need to do follow-ups on that and avoid accumulation of the drug, or these two main adverse effects will show up. Now, regarding the lab values, because it's different from each patient, we don't have a specific set. So basically, it will be a baseline based on that patient. Now, just like any other antibiotic, they can cause allergic reactions, rash, anaphylactic reaction. So you need to be aware and on how to identify the symptoms. Usually, again, every time you give an antibiotic, the first 30 minutes are crucial because if something happens, something severe is gonna happen. It's gonna happen in 30 minutes. Now, this is new regarding the antibiotics. Aminoglycosides are not advised to give to patients that are using a neuromuscular blocking agent. It's not advised on patients under general anesthesia or patients with a history of myasthenia gravis. So if you remember myasthenia gravis, we saw them on the first week of this term. And we mentioned that this group of patients, they have a progressive debilitating condition where the muscle stops to react as the day go by. And usually it's on the face. They wake up in the morning and this patient is okay. They have breakfast. They're smiling. They're having normal muscle function. But the day goes by, they get more tired when they're chewing. They don't want to eat that much as the day progresses. By the end of the day, they cannot move the face. They're drooling. Obviously, they cannot have dinner. So myasthenia gravis, aminoglycosides is a big contraindication. So overall, any condition where the patient is having some type of a muscle paralysis and a flaccid condition, aminoglycosides are not advised. If this happened, if for some reason the patient is given an aminoglycoside and we find out late that they have a condition or they're using a drug that produces a flaccid paralysis of muscle, then this is your antidote. Calcium gluconate. Again, we're giving calcium because calcium helps with muscle contraction. And that's what we want. We want to save that patient, especially if we're affecting the diaphragm. Then we can reverse the effects of the aminoglycoside with calcium gluconate. So high heel information right here. Besides that, well, you know what? Hypersensitivity reactions, just like any other antibiotic. Regarding blood dyscrasias, we're talking about the penias again: leukopenia, neutropenia, lymphopenia. Regarding the drug interaction, well, you know, if we're talking about infections, we can mix it with other antibiotics in order to have a bigger antibiotic effect. But regarding adverse effects, well, what you mentioned, aminoglycosides is not advised to be mixed with a medication that produce flaccid paralysis and with IV penicillins, especially when both of them they have to give in the same time. So we mentioned this on the chapter of penicillins, that if you have an odor of gentamicin with penicillin G at 9 a.m. IV, both of them, you know, you need to question that order. You need to go to the charge nurse. You need to call the doctor and see if he can give you a new order for, I don't know, penicillin at 9 a.m. and gentamicin of, I don't know, 10 or 11 a.m., you know, at least an hour apart. If both medications are given at the same time, when they interact with each other, they're going to crystallize. And that can bring serious damage to the vascular system of a patient. Basically, will have serious internal bleedings. So the serum levels is gonna be based on the dose. You know, the doctor can provide a QD order. So this will be one large dose, or we can say, hey, you know what? I want the dosage given BID or TID, 2 or 3 smaller doses. And like I told you, unfortunately, we don't have a specific drug level for this one because it depends on the patient. So we need to make sure that we follow those serum levels and make sure that it doesn't too high. It doesn't go too high, and we need to look for those ototoxicity symptoms. And real quick, ototoxicity symptoms: the patient's gonna have trouble hearing, deafness. They're gonna have a balance problem. They're going to, you know, have vertigo or everything spinning. Or the other one that I forgot to mention on the previous chapter is tinnitus, ringing out the ears. So those three are the symptoms for ototoxicity. And regarding nephrotoxicity, what we need to do follows with a BUN and creatinine clearance. So it's very common for doctors to ask for peak and trough levels with aminoglycosides. So aminoglycosides on the hospital is going to be IV or it's going to be intramuscular. So if they ask you for peak levels, it has to be 30 minutes after intramuscular injection or after completing a 30-minute IV infuse. So once we finish the IV infuse or 30 minutes after that intramuscular injection, that's when we look for peak levels. So again, a key number here is 30 minutes. And if you notice, we don't push the antibiotic, we infuse it at least 30 minutes. If they ask for trough levels, then the sample has to be collected just before the next dose. So the NCLEX, the HESI, they like to put you on case scenarios where they want you to see if you know when to get peak levels or trough levels. So very careful with this slide. The most common aminoglycoside use is on a hospital level is gentamicin. Again, has the mycin ending. Very good for aerobic gram-negative bacilli. Like I told you, this is bacteria or the infections are in contact with air. We did mention Pseudomonas a couple of times now. So Pseudomonas on the burn unit, on the skin. E. coli, Klebsiella, Serratia, Proteus. Usually these are for, we see them a lot on UTIs. But like I mentioned, the hospital setting, when you are manipulating the patient with catheters and Foley's and procedures at the bed, sometimes we move bacteria around, and that's when bacteria like E. coli, Klebsiella, Serratia, Proteus, that we can find that usually in the GI tract based on manipulation or bronchoaspiration. Now they can be in other body parts and produce an infection. So again, the highlight regarding adverse effects, nephrotoxicity. So again, we need to do a lab follow-ups, BUN, creatinine, ototoxicity, and we mentioned here the patient is going to complain of a ringing of the ears, tinnitus, deafness, and dizziness, vertigo. Now, if the patient already has kidney problems, if the patient already has ear problems, if the patient already has or is taking a medication that produces flaccid paralysis, then aminoglycosides are contraindicated. So very careful on those type of questions. Other aminoglycosides, tobramycin, mecacin, neomycin, kanamycin, streptomycin, paromomycin. So you can see the common terminology is mycin at the end, with amikacin being the exception to it. So regarding the chapter, that is all. Thank you for your attention. Now I'll be seeing you on the next one.